Hi there! In this lecture we will integrate the knowledge you've learned in Module 4 with real-time patient cases. We will show you our considerations. So please think with us. Let's start with the cases. The first patient is a male, 64 years old, with a medical history of hypertension. He received a renal transplantation 1 year ago. His wife, 52 years old, was the donor. His maintenance therapy consists of prednisolone, tacrolimus and CellCept. 2 months after the transplantation, he had an acute rejection episode, for which he received high-dose prednisolone. 4 months later, he has a serum creatinine rise from 163 till 212 micromoles per liter, without proteinuria. There are no signs of urinary tract infection. The serum glucose is normal. The ultrasound and CNI levels are normal. So what are likely causes? And what is the pathophysiology? What are the diagnostic tests? And what is the treatment? Write it down for yourself and check if you're right in the video. So take a minute to look at the causes, the investigations which were performed and the results in this patient. So to exclude allograft rejection, a renal biopsy is necessary. To exclude toxicity of the calcineurin inhibitor, levels have to be checked. They were normal. Recurrence of the primary disease was not likely. In this patient, there was no urological obstruction. The ultrasound was normal. There was no urinary tract infection. PK virology was not checked yet. To exclude IFTA, a renal biopsy is necessary. We performed a biopsy and we especially asked if there was rejection or BK nephropathy.
Already from a low power view, we can appreciate that this is a renal biopsy with a massive interstitial infiltrate. Zooming in on this infiltrate, the majority of cells are lymphocytes, but there are also plasma cells present and an occasional multinucleated giant cell. The lymphocytes in particular affect the tubular epithelium, causing tubulitis. This cell shows an enlarged nucleus with a nuclear halo. The glomeruli seem to be unaffected by all this inflammation. Also vessels are normal, except for some mild, aspecific intimal fibrosis. Although the tubulitis would lead us to consider acute rejection in this biopsy, there are other changes which are atypical for rejection. The plasma cells, for instance, and the multinucleated giant cells, as well as the nuclear changes of the tubular epithelium. All these should make one think of a viral infection. And in the case of a renal transplant biopsy, a BK virus staining should then be performed. This is the result of the immunohistochemical staining. There are many more nuclei than the one showing the characteristic halo that are positive for BK virus. We should now consider whether we should have thought of other infections or an acute rejection as a concomitant condition. Another virus which can be found in renal transplants is CMV. However, CMV is characterized by nuclear changes described as owl's eyes, which were absent in the biopsy. Also, an additional staining for CMV was negative. Ruling out a component of acute interstitial rejection next to BK virus nephropathy is difficult, if not impossible. By studying the BK virus staining, it is important to search for tubulitis in areas where the staining is negative, like over here. This could certainly point towards a combination of BK virus nephropathy and acute interstitial rejection, and it is known that these two conditions often occur together.
Our working diagnosis was a BK nephropathy, although we could not rule out the combination with rejection. Since there were many areas positive for BK, we decided to treat that and to monitor closely. The treatment consists of reduction of immune suppression. In this patient, the CellCept was stopped. The renal function improved to values before the episode. You've already heard in this module about BK nephropathy. So what's important to remember? BK is highly seroprevalent and it is a latent infection in renal epithelial cells and lymphoid cells. Clinical disease occurs only among immunocompromised patients. The disease can occur as an acute interstitial nephritis, as seen in this patient, or stenosis of the ureter. Risk factors are treatment with tacrolimus and CellCept and high-dose prednisolone, as seen in this patient. The treatment is reduction of immune suppression.